Welcome to AETCM, the emergency medicine channel. Sure. Presenting the case of an 81-year-old male who presented to ER with history of gradual decrease in sensorium since the last 3 days, with multiple episodes of loose stools and vomiting since the last 4 days. On initial 10-second assessment, the patient was drowsy and was able to produce sounds but was not able to talk in full sentences as he was drowsy. And patient's airway was patent, but there was no pooling of secretions or gurgling sounds or stridor. Breathing, the respiratory rate was 18 per minute with a saturation of 96% in room air. And the air entry was bilaterally equal, and the chest was clear, and there was no presence of any added sounds. And circulation, the pulse rate was 76 beats per minute with a blood pressure of 110/70 millimeters of mercury, and all the peripheral pulses were palpable and equal, and the capillary refill time was 3 seconds. And the GCS was E3 V3 M2, and the pupils were equal and reactive to light with 2 mm. And the GRBS was 120 milligram per deciliter. And exposure, the temperature was febrile, and there was no presence of any rashes or any bleeding spots or any ulcers. And as adjuncts to the primary survey, we had initially taken a CBC total count. The CBC-CRP point of care was taken, showing a total count of 7,000, and along with platelet count of 1,56,000 and a CRP of 18. And we are also taking an ECG. ECG was showing normal sinus rhythm, and we are taking a VBG too, venous blood gas, showing there was no presence of any acidosis or alkalosis. HB was of 12, potassium was 3.5, and sodium was 147, with a glucose of 153, and a bicarb of
147 or 157?
Sorry, 157, with a glucose of 153, and bicarb of 19.3, lactate of 1.3, and there was presence of an anion gap of 11 with a creatinine of 0.93. And then we asked the sample history. Patient was an 81-year-old male with a known case of type 2 diabetes, hypertension. He had an old right large MC infarct on CV on 2022, following which he was bedridden and was dysarthric. He had come to ER with complaints of reduced sensorium, which was gradual in onset since the last 3 days. Initially, it was like he had reduced talk. Then he was able to produce sounds. So along with generalized tiredness, the patient also had multiple episodes of vomiting. The vomitus was contained food particles, and also there was no presence of any blood hematemesis or it was a non-bilious vomiting. The vomiting episode was not like immediately after food intake. And there was presence of loose stools too, multiple episodes, and it was not a presence of any melena was not present, and it was present since the last 4 days. And patient also had reduced food and water intake. So there's no history of any recent head trauma, or there was no presence of any recent catheterization for the patient, and there was no history of any headache or prior to the episodes, or any history of any seizure, history of urinary incontinence, and there was no history of any thinning of skin or like any moon-like facies in the individual. And we also asked the allergic history. He was not having an allergic history. And the medications, he was on tab metformin 500 mg, and he was on glimepiride 1 mg, and he was also taking cilnidipine 10 mg, and also ecospirin 75 mg, and atorvastatin 10 mg. And so the last meal was taken around 3 hours ago. And we are also sent the labs. So labs, we initially we had sent the total counts of 7,100, and HB was of 12, potassium was 3.5, sodium in the lab was shown to have 155, and glucose of 152. And we are also sent the serum osmolarity. Serum osmolarity was 341, and urine osmolarity was also sent. It was 960, and also urine sodium of 8. According to the classification of hypernatremia.
Okay, so what is your impression over here?
So this patient has basically come with complaints of multiple episodes of loose stools and vomiting and reduced sensorium. So we found out that he has an increased sodium and with a value of 155 lab sodium, and was also found to have a raised serum osmolarity with no significant increase in glucose level. So it could be solely due to the hypernatremia.
So basically it's a case of hypernatremia. Okay.
Yes.
So patient's serum sodium was 155.
Yes.
Urine sodium was?
Urine sodium was 960. Sorry, urine sodium is 8.
8.
Yes.
And the urine osmolarity
960, yes.
Fine. So let's come to the topic. What topic is what? Hypernatremia.
Yes.
Okay. What is hypernatremia?
Hypernatremia is a condition in which the serum sodium or the plasma sodium is more than 145 milliequivalents per liter, or there is also presence of a hyperosmolarity. So the serum osmolarity is more than 295 milliosmol per liter.
What is the normal osmolarity? Normal osmolarity.
Normal osmolarity is between 275 to 295 milliosmol per liter.
Okay.
So in patients with hypernatremia, they usually present with hyperosmolarity.
Okay. So you told serum glucose was not elevated as a significant finding. No?
Yes.
Why you mentioned that? What is the importance of serum glucose in this case?
Because in certain individuals, because patient is now moving towards has a history of reduced sensorium with multiple episodes of vomiting. There's a history of dehydration underlying. So there can be the presence of like glucose is also a hyperosmolar agent, which contributes to the osmolarity.
Yeah, correct. There are osmolarly active agents and osmolar neutral agents in our body. So glucose is one of the most common osmolar active agents in our body other than sodium. So in any normal patient, osmolarity of the blood is sodium dependent. But if you are having hyperglycemia over the level of 300, glucose will take over the osmolar role of the body, causing hyperosmolarity. So in this condition, you are basically telling glucose is normal, so hyperosmolarity is not secondary to hyperglycemia is what you are mentioning.
Yes.
But usually in hyperglycemia induced hyperosmolar conditions like HHS and DKA, not DKA but HHS, we get sodium value
More than 145. It's a hyper.
No, we get sodium lower. We get pseudo hyponatremia, hyperosmolar hyponatremia,
Yes.
isn't it?
Yes.
Which is usually volemic or dehydrated, secondary to falsely lowered sodium value. This is the mechanism. So in hypernatremia, usually glucose, if it is elevated also, the osmolarity, if hypernatremia is there, osmolarity elevation is secondary to sodium itself. It's not only due to glucose. Okay, glucose value is more important in hyponatremia rather than in hypernatremia. Okay, so now you have a hyperosmolar hypernatremia, isn't it? So what are the different types of hypernatremia? How can you classify it?
Hypernatremia can be classified on the volume status. So it's basically can be a hypervolemic hypernatremia. So in hypervolemic hypernatremia,
what are the three classifications?
Yeah, the hypervolemic hypernatremia, normovolemic hypernatremia, and hypovolemic hypernatremia. Yes.
What about hyperosmolar, hypoosmolar, isoosmolar? Is there any classification like that?
Usually hypernatremia, no hyper.
That is why we told in hypernatremia is there. Hyperosmolarity is the only finding you will get. You will not get hypo or isoosmolar hypernatremia.
Yes.
Got it? So hypernatremia is true hyperosmolarity. That's why there is no like in hypernatremia there is hyperosmolar, isoosmolar, hypoosmolar. That classification is not there. It's all hyperosmolar. So we will go directly to the second step. What is the volume status? You can have hypovolemia, euvolemia or hyperolemia. Okay. Now we will start with hypovolemia. Okay. So what is a hypovolemic hypernatremia causes or how will it present?
Yeah. So Hypovolemic hypernatremia usually presents with severe signs of dehydration. So there will be presence of like dry tongue, increased skin turgor will be dry skin. So that will be usually the presentation. It can be due to two reasons. It can be due to the renal cause or extra-renal cause.
Correct.
So the renal causes mainly can be due to the presence of any osmotic diuresis. So like in presence of hyperglycemia.
Which is more common, renal cause or non-renal cause?
Non-renal, extra-renal is more common because extra-renal can be in the form of diarrhea or vomiting, GI losses, or presence of burns. So that is usually will be presenting as hypovolemic hypernatremia.
Yes, correct. So extra-renal is the more common thing. Vomiting, GI losses, vomiting, acute diarrhea, and burns. Basically, any condition in which you lose
So the water more than the
water. Correct. Then you have renal cause.
Yes.
As you told, renal cause is secondary to hyperosmolar active substances like
can be glucose itself or mannitol.
mannitol. So, okay, now that's it, right? That's a concern. So,
And even post-obstructive diuresis,
Yeah,
like
post-obstructive
diuresis can also lead to renal hypovolemic hypernatremia.
okay. So, in this condition, let's discuss that. Now, hypovolemic hypernatremia. What is actually happening inside the body?
Inside the body, there is already a water loss inside. So there will be the presence of increased concentration of.
Is it only water loss?
No, water and sodium loss is already there, but the water loss is more than the sodium loss in the patient.
So water loss significantly outweigh the sodium loss, but there is both loss. There is water and sodium loss, but water loss is significantly higher than sodium loss. This is exactly why your vomiting, diarrhea, and even burns come in this, because significant amount of volume is lost from the body in a very short time, isn't it? Now, when you say volume loss, what volume are we talking about?
Talking about the intravascular one.
Extracellular volume. ECF is what we are talking about.
Yes.
ECF and intravascular is the volume status of our body, isn't it?
Yes.
Intravascular or ECF we can say. There is intracellular volume also. 70% of our total body is water is in intracellular volume. Only 30% is in ECF. So when we say there is hypovolemia, it is in ECF hypovolemia. So what happens in these kind of patients? Your water is lost, your sodium is lost, but water loss is significantly lower than sodium loss. So what is happening in ECF? Your sodium value will rise. That rise is secondary to water loss, not due to increased sodium presence. It's water loss. So ECF volume is reduced. So what will happen to serum osmolarity?
It will increase.
It will increase. So what will body do?
It will try to get it back to normal by ICF volume will be moved to the ECF.
So intracellular fluid will now shift to extracellular space, causing intracellular dehydration. Volume loss intracellular. Now, when intracellular volume shifts to extracellular space, what happens to intracellular sodium?
It also increases,
rises. This is why this is the basic mechanism of action. But if this action is not corrected, that is after diarrhea, vomiting, if the patient is not adequately replenishing water, the patient will go into hypernatremia. Because this loop will cause intracellular sodium rise, intracellular water deficit. And that is how patient develops neurocognitive complications. Okay. Now there is a volume loss, there is a sodium deficit. But total sodium in the body is deficit. But serum sodium levels are elevated. Okay. This is the same mechanism that happens with the osmotically active agents. Prime example is mannitol. You give mannitol for IC bleed patients or any elevated ICP patients. After 2 to 3 days, their sodium level will be very high, because mannitol is a osmotic diuretic agent. So you will lose lot of water in comparison to sodium. Again, it's a extracellular volume deficit. But there we want that so that ICP will not elevate. Okay, but mechanism is same. Now, what is the management?
So in such individuals, we must look the free water deficit. So that's the initial.
Calculation of water deficit will say last, because everything is same.
Yes.
What is the fluid of choice here?
We will ideally choose a free water, D5 water.
D5.
Yes.
D5. D5. Half NS. Anyhow, all of you are telling hypoosmolar fluids. Alle? Not isoosmolar fluid. No, none of you want isoosmolar. I want isoosmolar fluid. Why? You understood the question, right?
Yes.
D5, half NS, everything is hypoosmolar fluids. I would say isoosmolar fluids. NS, RL is 5. Why? Tell fast. Okay, leave that. You told non-renal causes.
Yes.
What are the non-renal causes?
It can be due to GI loss, vomiting, diarrhea, burns.
All these conditions, what is the fluid of choice? What is the fluid of choice?
Isoosmolar.
Isoosmolar. What you actually give? Ringer lighted, right?
Yes.
Or cabulite, ringer lighted, right? You don't give half NS, right?
Yes.
You don't give 5% distance, right? Why? There is a volume loss. You have to supplement ECF volume. So 5% dextrose you give, ECF volume is not supplemented. Where will 5% dextrose go? Through urine. You want solute water to supplement extracellular fluid space. So here the sodium is not elevated. The total body sodium is decreased. You have to understand your total body sodium is decreased because you have lost sodium. But your serum value is elevated due to more loss of fluid. That's a volume contraction. So you have to treat volume contraction. The ideal fluid of choice is NS, means isoosmolar fluids. NS, RL, doesn't matter. That's the fluid choice. This is why in all RL burns cases, you give ringer lactate. Okay. So indirectly that is the answer. Directly, this is why ECF volume contraction should be treated. So this patient, fluid of choice will be
isotopic.
NS or RL. Okay. So in volume contraction conditions, volume should be replenished. NS or RL is the fluid of choice. This is counter common sense because we will feel sodium is already high. Why we should give a fluid which is already full of sodium? The answer is volume replenishment. Sodium will not worsen. Why you know? I will tell. You told patients serum osmolality, urine osmolality and urine sodium. What were the value?
So the
Serum osmolality is
340.
340, elevated.
Yes.
Urine sodium is 157, elevated. So sodium is elevated, isn't it? Urine sodium should be elevated. What is the urine sodium?
8. Less.
8. What is the normal urine sodium? Less than
20.
This is 8. That means kidneys are not excreting sodium. Why? If sodium is elevated, kidney should excrete. This is not a sodium problem. This is volume problem. So if kidneys excrete sodium, kidneys will lose water also. That means more volume contraction. Okay. This is why this patient's urine is hyper concentrated. Your urine osmolality is 900.
Yes.
It is a concentrated urine. But the concentration, sodium is only 8. So why is it concentrated? Because volume is not there.
Okay.
Understood?
Yes.
I know you will say 5% stress. Okay. Now you got the idea.
Yes, yes.
So in hypovolemic hyponatremia, it's a volume contraction problem. It has nothing to do with sodium. Fluid of choice is always isoosmolar fluids. And how can you be sure? You check the urine sodium and urine osmolarity. Urine osmolarity is going to be very high, and your urine sodium will be very low, like less than 10. That shows that body is trying to conserve sodium. Got it? Just short. Euvolemic.
So
Euvolemic, right?
yes, sir. And
Yeah.
euvolemic hypernatremia can be mainly due to different central diabetes insipidus. So that can be one of the cause, or it can also be due to a nephrogenic diabetes insipidus. And also another
So
cause.
diabetes insipidus.
Yes.
It can be either central or it can be either nephrogenic. Okay. What is happening?
So it's the body's inability to concentrate the that is basically the functional pathology of diabetes insipidus. If it is due to the primary decrease in the ADH secretion, it is called due to the central cause. So that's a central diabetes insipidus. If it is due to the vasopressin receptor, ADH receptor defect, it is a nephrogenic diabetes insipidus. So that's how the manifestation depends.
Okay. Basically, what is happening in the kidney, as you told, be it central, be it kidney, what is the problem? You told urine cannot be concentrated. What does that mean? Polyuria. In other simple terms, your distal collecting tubules is losing a lot of free water. So basically, body cannot reabsorb free water. That is the concentrating mechanism. So at the end of the collecting tubule, if volume is more, body can always retain it, isn't it? That's normal mechanism. So in SADH, that is more. You are retaining more fluid. Here, say the inadequate excretion of ADH or the vasopressin analog receptors is not working even when ADH is there. This is what is happening. So basically what happens, your free water is losing through the
Urine.
tubules. So you are going to have lot of urinary loss of water. So what will be your urine osmolarity?
It will be in the lower reduced.
Very low, because in comparison to the salt that is excreted, the concentration of water that is excreted is very high. So you are going to have a very dilute urine, usually below 300. Usually below 300 osmolar urine will be there. And what will happen to urine sodium?
It will increase.
It will be near increase, more than 20 but less than 40. Okay, there is no salt excretion as such. It is a water reabsorption problem, like our SADH, what we say. Okay, it's the ultra of SADH. So you will have urine sodium elevated but not extremely elevated, less than 40, more than 20. But urine osmolarity is very low. Why? Because water is lost. Now, what will happen to inside our body? Will ECF change?
Yes, fluid loss.
ECF will not change. This is why it is important. This is free water loss. Free water is means without electrolytes. Okay. Since free water is lost, ECF volume doesn't change. Okay. But your sodium levels increase, because whatever substance you intake, you are taking a solute or you are taking some soda or whatever, the sodium from that is being retained in your body, but the entire water is being pushed off. So comparison to the water, sodium is retained, so sodium level increases. But volume as such is not increasing or decreasing. ECF volume is not lost. Water, free water is what is being lost. So what will happen? There will be some amount of sodium increase. No, there will be some sodium increase. To dilute that, intracellular fluid will shift to extravascular space. But the amount of shift will be very little because extravascular space is not diminished. But this will cause intracellular sodium to rise. So both sodium rise. Now, so you have a normal volume but elevated sodium. What will you give to correct this? What is the treatment of choice?
In case of central diabetes insipidus, we must go with desmopressin.
That is the drug of choice. How will you treat the patient? Like you need workup, no?
Yes.
To say it's central or nephrogenic. You got only urine osmolality, urine sodium, serum osmolality, serum sodium. With this, what will you start? What are you losing?
Water.
Free water. So what will you give?
Free water.
Free water. Okay. So you are going to give free water loss. Free water is being lost. So you supplement for free water to the patient. And what will you do to sodium? Reduce sodium intake.
Yes.
Reduce sodium intake. Increase water. Exactly opposite to your SADH. In SADH, what do you give? Don't give water, increase sodium. Here, you give water and decrease sodium. Got it? This is the fluid management. Now, you have central diabetes insipidus. You will give desmopressin. What is the dose of desmopressin?
Desmopressin is usually in the dose of in a desmopressin nasal spray is actually available. So that's actually 10 microgram. That's 0.1 ml given every 12 hours. So that's a nasal spray dose. Or we can give per oral also. It is given as 0.05 mg every 12 hours.
So 0.1 microgram.
10 microgram.
10 microgram as 1 ml. Nasal spray, 12th hourly, or
give per oral
0.5 mg of
0.05 mg every 12 hours.
12 hours. Okay, so you give desmopressin. Now coming to hypervolemic hypernatremia. This is a bit of what is more common. These three we told, no? Hypervolemic hypernatremia, euvolemic hypernatremia, hypervolemic hypernatremia. Which of these are the most rare to see?
Rare is hypervolemic.
Hypervolemic hypernatremia is the rarest thing to see. You will even see diabetes insipidus. It's not that rare anymore, but hypervolemic hypernatremia is a bit rare. Can you tell what is happening in hypervolemic hypernatremia?
In hypervolemic hypernatremia, there will be the presence of already sodium loss will be present, but the water also will be retained. So there will be presence of hypervolemic.
Is it sodium loss and water retention? Is that what is happening? No. Sodium loss and water retention, we are dealing with hyponatremia. What is happening here?
Sodium is also retained. Water.
Sodium is retained. Water is retained. But sodium is retained more than the comparison to water. This is a retention problem. So your ECF is going to be increased. Okay. ECF is going to be increased. It's a volume excess. That is hypervolemia, right? Okay. So you have to think about conditions in which you will retain water and sodium. Isn't it? So you have two different conditions. One is kidney, non-renal and renal. What are non-renal? Whatever we cause is non-renal.
Iatrogenic. We can if we'll give 3% like saline correction, sodium correction.
Present saline is correct, but not 3% saline.
Hypertonic saline.
Okay, hypertonic saline.
And
saline.
Yes.
Over fluid resuscitation. Trauma pushed in 5 to 6 liters of fluid. Patient is going to have hypervolemic hypernatremia. Sepsis, severe fluid management, 4 to 5 liters given. Hypervolemic hypernatremia. Even NS can cause hypervolemic hypernatremia. It's basically the amount of sodium and water retained in the body. So you push a lot of water, solute water into the body. Patient's volume and solute is going to be increased till it is being excreted out. If it is NS, it will be excreted out gradually over some time. If it is 3% saline, which is given overzealous, it can cause. Okay, so that is one thing. But what is a drug that can cause significant hypernatremia with hypervolemia? You guys haven't used that very common. You guys have. No. Tolvaptan doesn't cause. Tolvaptan corrects a already existing pathology. How can it cause a new pathology? You have given that drug lot of times. Sodium bicarbonate. Sodium bicarbonate is a hyperosmolar solution. Contains nearly 3 times the sodium of 3% saline. So you give sodium bicarbonate, your sodium is going to go through the roof. Your osmolarity will be significantly elevated and you will have water retention. So non-renal is basically either increased, is basically iatrogenic, in that either you are giving overzealous isotonic fluid resuscitation or incompatible 3% saline introduction or sodium bicarbonate solution. So where will you see sodium bicarbonate causing hyperosmolar hypernatremia? Dialysis. Say. Cardiac arrest. Cardiac arrest is what? Tell no. Cardiac arrest. You will give hyperkalemic cardiac arrest, you will give sodium bicarbonate. If you are significantly given more than the adequate dose, patient will develop hyperosmolar, hypervolemic hypernatremia. Okay, now renal. What is the renal cause?
Renal can be
Kidneys taking up sodium and water into the body, not excreting.
Excreting. Hyperaldosteronism.
Yes, Cushing's.
Cushing's and hyperaldosteronism.
Increased mineralocorticoid activity. Increased mineralocorticoid activity like Cushing's or medicines that we give. We give mineralocorticoid for patients having postural hypotension. So these patients can go into hyperosmolar hypernatremia. So how is your urine going to be?
The osmolarity will be increased.
Urine osmolarity will be normal. More than 300, less than 800. Because sodium and water is retained. But your urine sodium is going to be low. Urine sodium is going to be low, but normal osmolarity. Okay. In hypoosmolar, you have urine sodium low, but increased osmolarity. Here it is urine sodium low with the normal osmolarity. Okay. In the other hypervolemic, you will have increased sodium loss with increased osmolarity. Urine osmolarity will not increase like preserved urine osmolarity. Okay. What is the treatment for hypervolemic hypernatremia?
It's mainly in the form of
you are retaining salt and water. So what is the drug of choice to remove salt and water? Diuretics. Salt wasting diuretics is your choice. So all the salt wasting diuretics you will withhold for a hyponatremia. You should start in this case. It will remove salt from the body, it will remove water from the body. That's the treatment. Okay.
Yes.
Mineralocorticoid excess is there, we should treat it separately. Okay. So this is basically hypernatremia. Okay. Now comes to the water deficit. So we told in most of these cases there is a water deficit associated. But you have to understand water deficit is only in certain condition, not everything. For example, euvolemic hypernatremia, there is a free water deficit. So that is the pure case in which free water should be given. That is 5% dextrose or free water. In all other conditions, it's either isotonic fluids or fluid prevention of fluids, isn't it? Okay. Here, so you have free fluid loss, right? So how will you calculate how much fluid to be given to a hypernatremic, euvolemic hypernatremic patient?
Pneumonia hypertensive patient usually there's a formula for it. It's in liter. So the percentage of the body water, total body water in fraction. So the percentage of total body water it depends on the age and also the sex of the individual. So in adult male it is 60% the total body water. So that's 0.6. We take it as fraction. In adult female, we take it as 50. So that is 0.5. We take it as fraction. In elderly male, we take it as 0.5. That's 50% as fraction. And elderly female, we take it as 0.45 or 45% is taken as a total body weight fraction into the ideal body weight. And it is also again multiplied by the current sodium minus the desired sodium. So that is the ideal sodium divided by the ideal sodium. So that's the formula which is used. Or we can tell it as the current sodium divided by ideal sodium minus 1, whole minus 1.
So in this case it is 155 minus desired sodium, that is 140 divided by desired sodium 140 the whole minus 1, isn't it? Into point male or female?
Yes, it's a male elderly male.
Elderly. So 0.5 into lean body weight, whatever. This will give you total free water deficit of the patient. That is how much free water you have to give to completely resuscitate patient sodium back to 140. This is what you are calculating. Okay, so let's say it comes around 3 liters. How will you give 3 liters?
So that the administration of fluid, it is also depending on the presentation. So the duration of presentation is what it depends on. If patient is presenting with the symptoms within just less than 6 hours prior, so and the patient also if gives a history of a lethal sodium dose intake, patient may, if he is a psychiatric patient, has taken an increased amount of sodium chloride, so has taken of like a dose of 0.75 to 3 gram per kg sodium chloride had been taken for the individual, we can go for an aggressive correction within 1 to 2 hours. So that is, we usually give it with D5 water or free water within 1 to 2 hours, or we can also go for an alternative as hemodialysis. So that is the option in case of acute hypernatremia presentation, which is presenting less than hyperacute.
Can you tell me one condition in which patient can take this much amount of salt in this much less duration? Capsule. Through capsule. No patient is going to eat sodium with his tongue. Okay, 3 gram per kg. That is 150 plus gram of sodium. Okay. So someone takes intentionally. This is the only way it can happen. Okay. Other conditions.
So if his onset is less than 48 hours, so then we can, the correction rate of we can use D5 water, or we can use, if patient's sensorium is better, we can use oral free water also, or through the right tube also we can give oral free water. And the correction, the decrease of sodium should just be at the rate of 1 milliequivalent per liter per hour. So maximum we can reduce only up to 24 milliequivalents maximum in 24 hours. So that is in cases of presentation less than 48 hours.
Maximum 24 milliequivalents we can decrease. Don't say like that.
So ideal. Then in chronic hypernatremia, if patient onset is more than 48 hours, the rate of correction is more slower because it can lead to overcorrection, can lead to cerebral edema. So that's why we must give a correction of only 0.5 milliequivalent per liter per hour. So maximum of 10 to 12 milliequivalents. Sodium. Per 24 hours must only be the sodium be reduced.
Okay. So what about no, this is chronic correction. Okay. So you calculate the total free water deficit and calculate the desired sodium correction, that is 10 milliequivalents, and accordingly you start the patient on free water. So 3.2 liters is the free water deficit. If it is acute, we can divide it by 24 hours and see how much you are to give. Or you taper it down to much more lesser value and start per hour, whatever value you are getting to correct sodium, and repeat sodium every 6th hourly and see, isn't it?
Yes.
Okay. What will happen if you overcorrect? Like for chronic hypernatremia, you corrected very fastly, 50 milligrams cleared in 12 hours or 16 hours. What will happen?
So in fact, there will be presence of like balloon, like in ballooning. So the increase in the size of the cells in the brain. So it will lead to cerebral edema in the individual.
There is cerebral edema. This is the complication. As we told, almost all hypernatremia will cause intracellular dehydration. Not only extracellular, intracellular dehydration. So when you give fluid correction, the first volume to be corrected is going to be intracellular. So if you are fastly correcting, your osmolarity will also change, causing sudden increase in intracellular volume inside the cells, causing cells to balloon up, causing intracellular hemorrhage, edema, causing seizure syndrome. Okay, so this is the complication. So anything to add? Okay.